Professor Kalana Kenji here, and we're discussing the last final module of sectional anatomy. This discussion will be on the lower extremity. All of my slide presentations has been approximately 50 slides, 51 sometimes when I felt really good. This presentation right here is 63 slides, so it will be a little bit more information than we normally get. Okay, we're going to start off on page 654, and the complex anatomy of the lower extremity is responsible for bearing the entire upper body weight and for accommodating the demands of movement placed on this system. This unfortunate person has bilateral cognitive fractures of the bilateral lower extremities. Look, the orientation of the bones look like they jumped off of a high building rather than something like an automobile accident. There's hardly any angulation, but there is some distraction of the bones. Okay, so this slide we have a T1 weighted MRI of the right hip, and the anatomy that we need to be familiar with from this image, selecting my pen again, is the rectus femoris muscle, the sartorius muscle. Major muscle wraps around to the lower leg, is the longest muscle, as we described in I think the PowerPoint presentation, with the pelvis in it. So this is a muscle that you should be familiar with. The iliopsoas muscle, iliosoas. So this muscle originates from the psoas muscle of the lower back, femoral artery, the femoral vein, the anterior acetabular labrum, right? The little cushion between the acetabulum, the bones of the pelvis, this is the pubis bone, ischium, head of the femur right there. So that's the labrum of the acetabulum. We even see acetabular fat within the acetabular fossa. So you're going to have some high signal fat inside of the fossa there. This is the acetabulum, this is the fossa of the acetabulum. So it's normal to see some fat in there. The obturator internus muscle, we talked about that one extensively in the pelvis. Or the sciatic nerve, right there, right where this piece ends, is a little sliver of a nerve right there. That would be the sciatic nerve. And there's the obturator internus tendon. So we know that anything that shows up with this type of signal in a T1 weighted image is going to be a tendon. It could be a tendon. Let's not say it's going to be a tendon, but it could be a tendon as well as a ligament. Look at the iliofemoral ligament here. So that's the greater trochanter of the femur, and here's a good shot of the gluteus medius muscle. The gluteus medius muscle wraps all the way around to the front. See, when we think of the glutes, we all think of the hind ends, but we see here that the gluteus medius muscle does wrap around the front. And here's a T1 weighted MRI of the right hip. So this is a coronal image. So there we have the ASIS, or the anterior superior iliac spine, the ilium gluteus medius muscle. All of this right here is the gluteus medius muscle. And then you have the iliotibial band. Iliotibial band. So this band stretches all the way down to what? The T, tibia. And you have the gluteus minimus muscle. So right here is the So right here is the demarcation of those two muscle groups. So you have the gluteus medius and you have the gluteus minimus, and this is the femur. So we had the femoral head right here, and sitting inside of the acetabulum, of course, there's the acetabular fat again, that little acetabular fat right up there. The obturator internus muscle, the ischium, the lesser trochanter is important because this can symbolize the end part of the scanned abdomen. So the most inferior portion of the abdomen that you're scanning, if you are scanning the abdomen indeed, could be the lesser trochanter. Some people want to include the entire symphysis pubis. Some people say get down to the lesser trochanter. I tend to get the lesser trochanter just so I can involve all the contents of the rectum and anus. There's a lot of pathology in that region. So of course we want to know the acetabulum, the femoral head, and of course the femoral neck coming down there. So this is a CT shaded surface display image. It might be a volume rendered image, but they say 3D CT of the pelvis and hips. So the femoral head is covered entirely by articular cartilage with the exception of a small centrally located pit termed the fovea capitis. So if we were to take or segment out the femur right in the middle, and this is the pelvis, but if we was to put on our x-ray vision and just try to see the continuation of the femoral head, you will see a little dip in the femoral head, and that's called the fovea capitis, and is a ligament that attaches it to the acetabulum. And the ligament that attaches it to the acetabulum is actually called the ligamentum teres. So the fovea is the divot, and the ligament that attaches it to the acetabulum is called the fovea teres. And this is a good picture of the fovea capitis, which is the indentation, and then you have the ligamentum teres, and it's cut here, but it wouldn't be cut. So this piece right there would be attached to that piece, but this is the ligamentum teres, and it attaches it to the acetabulum. So we have the ischium, which forms the bottom portion. You sit on your ischium, and the pubis is in the front and anterior. So remember, you can palpate the pubic bone or the symphysis pubis, and when you do, you palpate in the anterior portion of the body. Good picture, illustration of the acetabular labrum. Remember that the labrum is highly sensitized region and can be painful to the touch, or especially to the needle, even if anesthetic is injected inside of the joint. So here's another illustration of the posterior view of the right hip joint, and we call it a joint because now it's fully encapsulated, so all the synovial fluid will be located right there, right in the middle of the joint. So we're looking at a posterior view. So right here would be the ischium coming down there. You have the lesser trochanter, you have the greater trochanter. This is the back of the femoral neck. Okay? So you have the ischiofemoral ligament, and you have the iliofemoral ligament. And they named the ischiofemoral ligament because it attaches to the ischium of the pelvis and the femur. And then you have the ilio because it's attaching the ilium to the femur. Coronal T1 weighted MRI of the hips with the ligaments and labrum attached to it. So the femoral head is held to the acetabulum by the acetabular labrum and several other major ligaments. Remember the ligamentum teres. The acetabular labrum creates a fibrocartilage rim attached to the margin of the acetabulum. The inferior margin of the acetabulum is incomplete and is reinforced by the transverse acetabular ligament. So here's a coronal T1 weighted image, and we see the transverse acetabular ligament is the end of this line right there. To orient yourself to what we're looking at here is the coronal slice of what we're looking at. So you can tell that this is fat. Of course, this is muscle, just from the grayscale that we see. So we know that this is air, so this is air. Okay, so this is air. So we have the gluteus medius muscle, gluteus maximus muscle. We have the iliofemoral ligament. Good picture of the iliofemoral ligament right there. Remember the iliofemoral ligament is that ligament that's connecting or is providing a border for that joint capsule of the hip, connecting the ilium and the femur together. So we have the femoral neck, not too difficult. The greater trochanter, we know that. And the ischiofemoral ligament, which is connecting, remember the ischium, the part of the pelvis bone that we sit on, to the femur. So now here we have a T1 weighted MRI of hip with ligaments and labrum. So the another ligament called the iliofemoral ligament is among the strongest of the body. The iliofemoral ligament is one of the strongest ones of the body, with many stabilizing functions as it spans from the anterior and inferior iliac spine and rim of the acetabulum to insert on the enterotrochanteric line of the femur. So it's a very, very strong ligament, this iliofemoral ligament. It must be, because it absorbs a lot of stress. It keeps that femur, it keeps the femur in place. And remember, all of the weight of our torso is torqued onto the femur anytime we change direction. So it's important that that ligament is indeed strong. But it attaches, it spans from the anterior inferior iliac spine to insert on to the femur. So here again, a sagittal view. We want to understand the acetabulum, of course, the iliopsoas muscle, the femoral head, obturator externus. The obturator externus. Remember, this the obturator externus muscle right there. The obturator internus is on the internal aspect of the obturator foramen. So here we got that transverse acetabular ligament. And if you want to orient yourself again, take a look at the picture. Take a look at both pictures so that you can see exactly the sagittal slice, the orientation of the sagittal slice. Another view of the posterior acetabular labrum, because remember the shoulder and the labrum. You know, it's just the right there, the little cushion, the little layer of the acetabulum. Ischiotuberosity, we know that tuberosity is like a jutting of the bone itself, and the huge gluteus maximus muscle and the piriformis muscle. We learned about that in the pelvis. Okay, this is an axial oblique MRI orthogram of the hip. How do you know it's an MRI orthogram? Because the joint space is opacified with gadolinium. So like a fat sat image of the hip. This image can be found on page 10. I'm sorry, not page 10, page 664. And the anatomy that we should be familiar with, of course, the femoral head and femoral neck. We should be very conversant with that. We learned the iliofemoral ligament that It's the outside joint capsule. So we know that this is the joint capsule because it's highlighted with contrast. So the border of that joint capsule would be the ligament. Well, we know that this is the iliofemoral ligament just because of where it is. It's the anterior portion, so it's going to connect to the anterior inferior iliac spine. It couldn't be the ischiofemoral ligament because the ischium is back here. So that's why you know that. Posterior labrum because it's posterior. Acetabular fossa. Articular cartilage. Actually, I would zoom this back just a touch because it looks like it's inside the joint space in the anterior labrum. So we learned about ligamentum teres, that is a flattened band that extends from the fovea capitis of the femoral head to attach to the rim of the acetabular notch. So the ligamentum teres is what's going to be that ligament that attaches itself to the acetabulum. And the joint capsule, of course, we know that the joint capsule is surrounded by the iliofemoral ligament, the ischiofemoral ligament. But the fibrous capsule of the hip joint is strong and is very dense. It forms a sleeve that encloses the hip joint and most of the neck of the femur. So most of the neck of the femur is enclosed within this joint. That's why when we do orthograms, we have a wide degree of variance and where we can place the needle to inject contrast into the joint. And it is a synovial joint. The synovial capsule of the hip joint lines the internal surface of the fibrous capsule. The synovial capsule forms a sleeve for the ligamentum teres, lines the acetabular fossa, and covers the fatty pad in the acetabular notch. And also the hip has major bursa. So we're on page 667 now. Major bursae of the hip include the trochanteric, iliopsoas, and ischial. The bursae that make up the trochanteric or the subgluteus maximus bursae are located between the insertion site of the gluteus muscles as well as the vastus lateralis muscle to the greater trochanter of the femur. So the vastus lateralis muscle is one of the quadriceps of the leg. The vastus, the quads, the hamstrings are in back, the quads are in front. Okay, so the vastus lateralis is part of the quadriceps. We'll learn about. We'll definitely look at the vastus lateralis muscle. And actually, a good picture of the bursa is figure 1027 on 667 at the bottom. And the bursa is a cushion. Remember that bursa is a cushion. So we have the muscles of the gluteal compartment, page 668. It's an excellent illustration of the superficial muscles of the right hip and thigh. We do see the gluteus medius, gluteus maximus, the iliotibial tract, and long head and short heads of the biceps femoris, semitendinosus, semimembranosus, adductor magnus, and gracilis. Now, since we're talking about the superficial muscles, if we was to take out the gluteus maximus, we would see the underlying muscles of the hamstring much better. But the superficial gluteal muscles include the gluteus maximus, the gluteus medius, and the gluteus minimus. The gluteus maximus is the largest and most superficial of the gluteal muscle groups. It is situated on the posterior aspect of the hip joint and acts primarily as a powerful extensor of the hip. So it extends the hip. The deep group of muscles include the piriformis, obturator internus, obturator externus, gemellus, and quadratus femoris, which are mainly lateral rotators of the thigh at the right hip joint and act to stabilize the hip joint. The piriformis muscle originates from the inner surface of the sacrum between the sacral foramina. So we talked about the piriformis muscle when we discussed the pelvis. Okay, sagittal, T1 weighted MRI of the hip with the muscle. So to orient ourselves, we know that we have the femoral head right there. We have the acetabulum right there, and specifically the ilium. We're going to look at our picture here, and we know that we're taking a sagittal image. So we know we're going from anterior to posterior. So we're going from anterior to posterior there. That's a good shot to illustrate. And we're not going down the knee here. We're actually going to stop this picture from there to pretty much there. Okay? So now we're oriented to where we are, and let's begin to talk about the anatomy. The iliopsoas muscle originate from the psoas muscles, go into the iliacus muscle, and they both combine and form this iliopsoas muscle that attaches to the hip. So that's why the psoas muscle is important for runners and joggers. And when you see athletes, their psoas muscles are huge because it is a flexor of the hip, and this muscle acts to pull this hip forward so that they can get a good stride. Okay, we have the gluteus minimus muscle and the gluteus medius. So we have the gluteus minimus. There's the dividing line, and then you have the gluteus medius, and there's your dividing line, and then we have the gluteus maximus. Here's the little tip of the piriformis muscle. And we pick the iliopsoas muscle back up again. So we have iliopsoas muscle right here coming down the anterior portion, and we pick the iliopsoas muscle back up again. We have the pectineus muscle and the adductor magnus muscle, and these muscles actually insert into the pelvis. So figure 1031, I'm on page 669. T1 weighted MRI of the gluteal region, and right here we could see a very, very good shot of the gluteus maximus, the gluteus medius, and the gluteus minimus. We can easily identify the borders. If we even come over here, we know the gluteus minimus is right there, gluteus medius and gluteus maximus right there. You have the psoas muscle, and you have the iliacus muscle. There you go. Psoas muscle meets up with the iliacus muscle to form the perfect iliopsoas muscle. You have the rectus abdominis. This is your six-pack. You want a six-pack, you do crunches. This is what you want to build up. You have the recurrent epigastric artery too that comes up through here. They call it recurrent because it travels down. It travels down with the pelvic group of vasculature, and loops around the greater trochanter of the femur and comes back up the anterior abdomen. So it's called a recurrent vessel because it changes direction. Okay, so now we have an illustration. 1042 axial view of the femur, the distal third of the femur. And this image is on page 674. So it's the distal 1/3 of the femur. And the muscles of the anterior thigh compartment. We can talk about the muscles of the anterior thigh compartment here. The muscles on page 672. The muscles in the anterior compartment of the thigh act both to flex the hip joint and extend the knee joint. So the muscles in the anterior compartment, the front part of the thigh, if you tap on it, is used to flex the hip, bring the hip closer to the body, up to the chest, and is used to extend the knee, straighten out the leg. Okay, So moving further down, the powerful iliopsoas muscle is composed of the psoas major and the iliacus muscles. We saw that on the previous slide. The psoas major muscle arises from the transverse processes of the lumbar vertebra and courses inferiorly within the pelvis. The sartorius muscle is known as the longest muscle in the body. It extends from the anterior superior iliac spine to the medial surface of the tibia near the tuberosity. The biggest muscle in the body is the quadriceps femoris muscle, which covers almost all of the anterior surface and sides of the femur. It originates as four heads: the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedius, to create a powerful extensor of the knee. The superior ends of the four heads of the quadriceps femoris muscle arise from the different locations, but their inferior tendons merge to form the quadriceps tendon that covers over the patella. The patella. So when people talk about their quads, they're talking about that the biggest muscle groups, the largest muscle groups that come almost the entire anterior surface of the leg. So the quads are in front. The hamstrings are in the back. And the quads, again, important to understand the quads. It's four muscles, hence quad. Rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. So we have a axial weighted T1 MRI of the right distal femur, and here we have a picture of the rectus femoris, the vastus medialis, okay, the vastus lateralis, all this, and the vastus intermedius. And you can understand why they call this what they call this. Remember, this is lateral, this is medial. Okay, so this is the medial. That's why this is the vastus medialis, because it's medial. It's the inside. It's the anterior medial part of the thigh. The rectus femoris muscle, the vastus intermedius, because it sits inside of the vastus lateralis, and it's the vastus lateralis because this is the lateral body. So the vastus lateralis, vastus intermedius, vastus medialis, rectus femoris. That's this entire group. That's this entire group of muscles. We just named the entire group of muscles. That's your quads. Your hamstrings are back here, okay? So we have a coronal T1 weighted MRI of the right hip and thigh. And we have a good picture of the iliotibial band, okay? So the iliotibial band, also called the IT band, is a long, wide band of fascia that lies over the muscles on the outer surface of the thigh. The band is a thickening of the normal fascia that surrounds the entire leg. So it's a thickening of the normal fascia that surrounds the entire leg, okay? It arises from the tendinous fibers of the tensor fascia latae and the gluteus maximus muscles. So that's where the IT band comes from. Good picture of the vastus lateralis. Look, we have the sartorius here. So we know this sartorius muscle is at this point medial, but it starts out lateral. So this sartorius muscle actually wraps all the way around, okay? And you have the vastus medialis, because it's medial. Remember, this is medial. Pectineus muscle, right there, attaching onto the pelvis. As a matter of fact, sometimes when you take an X-ray, you'll see like a real ragged looking ischial bone of the pelvis. That's because calcifications and arthritis and just pulling of the bones, including the hamstrings and the quads, on the ischium. One of the indentations is from the pectineus muscle. When you do a X-ray, if you do an X-ray of the hip, just look at especially older hips, patients in their sixth and seventh decades of life. Look at their hips and just look at how deformed the hip, the ischium, and the pubis bones are. That's just from years and years of wear and tear of walking and exercise and things of that nature that begins a degenerative process of the hip. So here is a coronal T1 weighted image of the right hip and thigh muscles. And so now we got to talk about adduction. So adduction is towards the body. Abduction is away from the body, right? So the muscles of the medial thigh compartment, adduction is the primary action of the medial thigh muscles. These muscles include the gracialis, the pectineus, the adductor longus, adductor brevis, and the adductor magnus muscle. So all these muscles are called adductors because they adduct the thigh, or bring the thigh back into midline with the body. Here's one of that group, the adductor magnus, right there. And we discussed a little bit about the pectineus muscle. So the arising from the pectineal line of the pubis is the short, flat pectineus muscle. So that pectineus muscle is one of the muscles that is pulling on the pubic bone. It lies medial to the psoas major muscle in the superior thigh, then narrows as it courses inferiorly to insert on the medial lip of the linea aspera at the pectineal line, distal to the lesser trochanter of the femur. So is the pectineus muscle has an insertion point of the pubic bone, and the other insertion point is distal to the lesser trochanter of the femur. So here's an illustration of the distal femur, the knee joint. You see the patella, just in case we have to orient ourselves to where we are. So of course we know the femur, patella, medial condyle, lateral condyle. The intercondylar eminence is on the tibial bone. So you had a tibial plateau. The intercondylar eminence is right there at the tibial plateaus, and you have Gerdy's tubercle, little jutting of the proximal tibia, the fibula, tibia, and the tibial tuberosity. And here's a T1 weighted MRI of the distal right femur. So I think this would be a good opportunity to begin the discussion on the muscles of the posterior thigh compartment. Remember, the posterior thigh compartment is the hamstrings, the semitendinosus, the semimembranosus, and biceps femoris are collectively known as the hamstrings. The hamstrings are 3 muscles. The quads are 4 muscles. The hamstrings are 3. The 3 semitendinosus, semimembranosus, and biceps femoris. Okay, so you have the tendon right here of the semimembranosus, the tendon of the semitendinosus, and you have the biceps femoris right here. So this will be one of the muscles, and this is the tendons of the other muscles of the posterior thigh. They make up the large mass of muscles that can be palpated on the posterior aspect of the thigh and are involved with extension of the hip and flexion of the knee. So extension of the hip is pulling of the hip down. So when you're getting up out of a chair, you're extending the hip. Okay? And flexion of the knee. So when you actually bending the knee or flexing the knee, that's flexion. And it also allows for rotation of the knee. Here's a picture of the sartorius muscle. We've been following this muscle all the way since the pelvis. Great picture of that. The gastrocnemius muscle. The popliteal artery lays right in this popliteal fossa. And this palpable artery is probably to me the hardest artery to palpate. You have to really get your fingers down in there and really have a nice indentation with your fingers down in there in order to palpate it. But it is possible to palpate it. And the iliotibial band, remember that fascia that covers the entire leg? Well, there's a thickened portion of it right there. So the sartorius muscle attaches on the medial aspect, where the IT band attaches is going to stay right there on the lateral aspect. So the IT band actually fans down. So at the top is a little wider, and then thins out as you traverse down to the tibia. Okay, this is a nice Corona T1 weighted MRI of the knee, and you're going to do plenty of knees, so you want to be very conversant with the anatomy of the knee so that you won't miss anything. So, the bones that contribute to the knee joint and lower leg are the femur, the tibia, patella, and fibula. So we have the femur up top, the tibia, the fibula, and the patella. We're kind of deep to that. This cut is kind of deep to that, so the patella isn't shown in this particular image. On figure 1056, page 682, shows everything. So the femoral condyles, medial condyle, lateral condyle. So the condyle is the big piece of bone. Epicondyle is the outer portion of the condyle. Epi means around, right? Okay, so the distal portion of the femur broadens into two articular cartilage covered projections called the medial and lateral epicondyle. The femoral condyles are anteriorly connected to the smooth patellar surface and posteriorly separated by the intercondylar fossa. So the tibia has a widened proximal end that has two cartilaginous projections, the medial and lateral condyles. The superior articular surface of both condyles has flattened surfaces called tibial plateaus. And this is the lateral tibial plateau, so this will be the medial tibial plateau. And then you got the intercondylar eminence, which is the peak, which is the two peaks. Those are the intercondylar eminences. So the tibial condyles are separated by this intercondylar eminence. Some people call it the tibial spine. Coronal CT reformat of the right femur. Know your modalities. This is a CT image, not an MRI image. So here we should be very conversant with the acetabulum, of course, the femoral neck, the greater trochanter, the femoral head, femoral shaft, the medial epicondyle, the medial femoral condyle, the lateral condyle, femoral condyle. This should all be very easy for us to identify at this point in time. So this is a sagittal MRI of the knee with the meniscus and the ligaments. This image right here can be found on page 685, and here you can see the quadriceps tendon and the patella. So you have the patella here. Remember, the patella sits high. So if the quadriceps tendon right here was cut from, how would you cut the quadriceps tendon? It might be hyperflexion of the knee. So if you flex this knee, hyperflex it, it pulls on this patella, right? Because you have a tendon, inferior patella tendon. And as you flex this knee out, it pulls this patella down, which could snap this quadriceps tendon and make the patella ride real low. Okay, so you want to make sure that you see the quadriceps tendon attached to the patella, the inferior patella tendon attached to the patella. So you have the lateral femoral condyle, gastrocnemius muscle, major muscle of the back of the leg, the tibial plateau, and this the lateral meniscus, posterior horn of the lateral meniscus. That's this dark area. You got to see that. That is extremely important in any type of knee injury. You must have a great picture of that. If you don't have a great picture of that during this particular examination, it's useless. The lateral meniscus anterior horn, because what they want to see is if this cartilage is detached, and they want to see if there's any soft tissue free floating in this meniscus. Because if it's free floating in this meniscus, then you have a torn knee, torn cartilage. Okay, arcuate popliteal ligament. This is the tibia. We know that. What am I saying? I'm so sorry. Fibula. We know that. The tibia. I was getting ahead of myself. We know that the tibialis anterior muscle is the little muscle that covers the anterior portion of the tibia, named properly. And now we have moved down to the ankle, and this image can be found on page 687. Let's go back to this, because there's some things that I do want to read so that you understand and know. Let's talk about some of the anatomy here. The fibula. The fibula is a long, relatively thin bone that has expanded proximal and distal ends. The proximal end is the head. The proximal end is the head, which ends in a sharp superior apex. The distal end forms the lateral malleolus, which extends farther distally than the medial malleolus of the tibia. You can actually live without the tibia, but it's a pretzel bone, and it's one of those bones that adds stability, like a truss on a bridge, but it adds stability to the lower legs. And also wanted to talk about the menisci. Located between the femoral condyles and tibial plateaus are the paired menisci. These C-shaped menisci, composed of fibrous connective tissue, cushion the articulation between the femoral condyles and the tibial plateaus, and are commonly divided into anterior and posterior horns. The medial meniscus is crescent shaped, with the posterior horn being wider than the anterior horn. The lateral meniscus almost forms a ring, a closed ring, with anterior and posterior horns of approximately the same width. So the knee joint. The knee is the largest and one of the most complex joints of the body. We're on page 689. The knee has three separate articulations, two femorotibial and a patellofemoral articulation within the same synovial membrane. The joint capsule of the knee consists of a strong fibrous membrane that is medially, laterally, and posteriorly reinforced by extracapsular ligaments. The synovial membrane of the knee is the largest and most extensive synovial body. Okay, and the ligaments of the knee are divided into external or extracapsular and internal intracapsular ligaments. This is on page 694. Make sure you read that paragraph. And then the external ligaments. The external ligaments of the knee include the collateral, patellar, and patellar retinaculum, and oblique popliteal and arcuate popliteal ligaments. Those are the external ligaments. Well, the internal ligaments, page 695, internal ligaments would be the cruciate, cross shape. Cruciate is just another way of saying a cross. So the anterior and posterior. Ligaments are a strong band of fibers that provide anterior and posterior stability to the knee. So the anterior cruciate ligament, or the ACL, arises from the medial intercondylar tubercle and extends to attach to the posteromedial surface of the lateral femoral condyle. While the posterior cruciate ligament is the stronger of the two. That's why many athletes always tear their ACLs. But if you tear your PCL with it, then you really did some damage. But it is the stronger of the two and extends from the posterior aspect of the intercondylar eminence to the anteromedial surface of the medial femoral condyle. It functions to prevent hyperflexion and posterior displacement of the tibia. Okay, so now we're axial T1 weighted MRI of the right ankle. I didn't want to leave the knee. I wanted to talk some more about the knee before we move down to the ankle and the tendons of the distal femur. Distal tibia. The tendons of the sartorius, gracilis, and semitendinosus muscle merge to form a conjoined tendon commonly referred to as the pes anserinus. It inserts onto the anterior medial surface of the proximal tibia, so high up, just superficial to the medial collateral ligament. With the exception of the popliteus, all muscles arising from the lower leg are attached to the bones of the foot. They are divided into the anterior and posterior group by the tibia, fibula, and interosseous membrane. So here we know that we're in the bones of the foot because we have the talus. Right there, extensor hallucis longus tendon. This tendon actually goes down to the big toe. The tibialis anterior tendon. The great saphenous vein. Extensor retinaculum. Lateral malleolus. Medial malleolus. The flexor hallucis longus muscle and tendon. All these are very important. Here's the Achilles tendon. It's very dark. The peroneus longus tendon. So this is the posterior foot. This is the anterior ankle, actually. This is a picture of the knee joint, and we jump back up into the knee joint. That's okay because we have to learn all this anyway. So this is an illustration of the knee joint. So there are more than 10 bursa located around the knee joint, owing to the number of muscles associated with the knee. So the knee joint has plenty of bursa because remember, all the weight of the body is constantly coming down on the knee joint. So it has to have plenty of bursa cushion. Has to have plenty of fluid in there. It has to be a very large joint to sustain the impact of the body day in and day out. But this is if you was to look down into the tibial plateau and the menisci. This is how this would look. This is the posterior cruciate ligament. This is the anterior cruciate ligament. So this wraps around and connects to the front this wraps around, connects to the back, and they kind of cross right there in the middle, and that's where hence the cruciate. The patellar ligament attaches to from the tibia to the patella, and then you have the quadratus femoris tendon that leads into the quadratus tendon that attaches to the patella superiorly. So here's the posterior cruciate ligament, the anterior cruciate ligament, and then you also have two side ligaments that stabilize the knee, also the medial collateral and the lateral collateral ligament. So the lateral collateral ligament connects the fibula to the femur. The medial collateral ligament attaches the tibia to the femur, and then you have the two cruciate ligaments that cross in the middle. So this is an MRI coronal T1 weighted MRI of the right knee with the meniscus and ligament. So you see the anterior cruciate ligament right there. This is the meniscus, and this is the joint, the padding. This is the actual meniscus. This dark area of fluid, lateral meniscus, dark area of fluid, and the medial intercondylar tubercle, the peroneus fibularis muscle, and the tibialis anterior, which crosses the anterior portion of the tibia. Sagittal T1 weighted MRI of the knee with the medial meniscus and retinaculum. So there's the meniscus again, the dark portions. You want to see those dark portions clearly. This is the articular surface. So you want to be able to see the articular surface, Blumenstadt's line. That's Blumenstadt's line. Vastus medialis, semimembranous muscle. So this is the hamstrings, this is the quadriceps. So this is the anterior, this is the posterior. Coronal T1 weighted MRI of the right knee with the arcuate popliteal ligament, the arcuate popliteal ligament. So here we have the tibia, the medial meniscus, the posterior horn and medial meniscus. So this is a picture of the arcuate popliteal ligament. So the arcuate popliteal ligament be right there and right there, and it's cut because we've taken a picture through it, but of course it connects. You have the lateral femoral condyle, the medial femoral condyle. This is the head of the fibula, the popliteus and tendon and muscle. So the tendon is the dark part, the muscle is this part right there, and then it leads into the tendon. So coronal T1 weighted MRI of the knee with the IT band. So you should be able to be very conversant with the IT band. The femur, the medial meniscus, right there. This is fat, vastus medialis, and the vastus lateralis muscle. We know that the vastus medialis and the vastus lateralis is part of the quadriceps femoris. So we have a sagittal section with the femur and patella. There you have a good picture of the posterior cruciate ligament, which is this whole entire black band. Okay, we know that this is the tibia. Oh, the soleus muscle, very important muscle. The gastrocnemius muscle, important muscle of the back leg. It actually is that big meaty portion of the back leg. Good picture of the popliteal artery and the popliteal vein. So we have the vastus medialis muscle, quadriceps, semimembranosus muscle, hamstrings, the posterior joint capsule, this area right there. Medial meniscus anterior horn. Yeah, of course I agree with that, but if we had another cut more immediately, we would see more of the meniscus, the black part of the meniscus. That's just really a really thin section. And as you can orient yourself right here, yeah, indeed it is part of the meniscus because it's part of that joint. We just cutting it very thin there. So we have an axial T1 weighted MRI of the knee with the patellofemoral joint. So here we have the gastrocnemius muscle, which is short here, and it'll get larger as we go more inferior into the lower leg. The popliteal vein, the tibial nerve, semimembranosus muscle and tendon. So we had a semimembranosus muscle and tendon. So we know that if we want to see this get larger, we have to go more superior into the thigh. Quadriceps tendon attaching to the patella right there, and then you have the articular cartilage of the patella. Very important to identify in MRI. T1 weighted or proton density weighted MRI is excellent at that. You want to also get a good picture of the IT band, make sure that that is indeed intact. Vastus lateralis tendon. See all of these tendons. So you know, if you're doing a person and their chief complaint is rupture of the quadriceps tendon, then you understand where to look at. Rupture of the tendons of the posterior thigh compartment or the hamstrings, then you want to know what to look at. Here's a good picture of the sartorius muscle. Remember, this muscle begins all the way up at the top of the ilium of the pelvis, and here we are down into the tibia. Patella, not patella, femur, and we still see the distal femur, and we still see the sartorius muscle. Again, sartorius muscle now we're kind of inferior to the patella. So, because they call this the patellar ligament. So the patellar ligament is going to attach to the inferior aspect of the patella and attach into the tibia. Biceps femoris. And we talked about the rest of these, so you should be pretty familiar with the anatomy on this image also. So now we're down into the tibia. This is where I want to be. We're moving down into the tibia, and you still see the patellar ligament. You see the IT band, hence iliotibial. We still going strong. IT band still going strong. Another thing that's still going strong, sartorius muscle down in the tibia. Very, very long muscle, the longest muscle. And the gastrocnemius muscle. CT, axial CT of the right knee with the cruciate and collateral ligaments. One thing I wanted to point out to you is the difference in the quality of soft tissue differentiation between MRI and CT. Here CT can give a good picture of the bone, but look at the difference in the anatomy of the muscle structure, the soft tissue. Fat, the contrast between fat, vessel, and muscle, much more pronounced in MRI than CT. As a matter of fact, CT we had to opacify. So this knee was actually injected. How we know? Because it's contrast in the popliteal artery right there. But we can still point out some anatomy here. We know this is the sartorius muscle coming down there, the medial collateral ligament, which is attaching the femur to the tibia, and the lateral collateral ligament, which attaches the femur to the fibula. Right? So we're looking at the very bottom portion of the patella, and then we're in the knee joint right there. So we're full of fluid. Biceps femoris attaching right there. Popliteus tendon attaching right into the lateral epicondyle of the leg. So we're taking a CT image, and this time we're going to go a little bit further down. So we're in the patellar ligament. We're inferior to the patella, and we have an infrapatellar fat pad. This is the knee joint in capsule itself, and this is the medial femoral condyle. Posterior cruciate ligament. Now, on CT, we really would not want to diagnose any type of tear to the ligament on CT. It's very, very hard to see in CT. As you can see, it kind of blends all this stuff into an image. You can see some differentiation of the muscle, but nothing like MRI. So CT is exquisite for bone, but soft tissue, MRI is much more specific than CT. So we have an illustration here of the lower leg. The peroneus longus muscle is on the lateral aspect, and on the medial and posterior aspect is the gastrocnemius muscle. The tibia, and you have, this is the tibialis anterior. So the tibia in this skin, so when you're pressing down on this, you should be able to feel bone. If you don't feel bone, is a layer of adipose tissue or fat tissue in between. The tibialis anterior lays just medial to, just lateral to it. So if you feel your tibia, your tibia, and just go just lateral to it, you're feeling, or you're palpating your tibialis anterior. The gastrocnemius is medial and posterior to it. The soleus muscle, the extensor hallucis longus tendon reaches all the way down and acts on the toes. So you can cut this tendon and have no action on the toes. You won't be able to extend the toes. Okay? The extensor hallucis brevis is the muscle that acts on it. Peroneus tertius. So axial view of proximal portion of the lower leg. So we're still up high, and this is an illustration. I like illustrations because they can clearly identify the borders of structure. So we have the tibia, the fibula, the soleus muscle, which lays distal or deep to the gastrocnemius muscle, popliteus, the great saphenous, which lays medial, because the tibia, the fibula lays lateral, the great saphenous vein lays medial, and you have, of course, the popliteal vein, the popliteal artery, and you have the nerve, the tibial nerve that's right in this little compartment. Illustration a little bit further down, and you see the soleus muscle start to become a little larger. The gastrocnemius muscle is starting to thin out. The fibula, the tibia, and right at inside of the tibia, medial to the tibia, is the tibialis anterior. You can palpate that. Okay, now we visited this slide a little earlier. The intrapatellar fat. The patella has a layer of fat around it to cushion it. Many times we fall on our knees, and the body understands that, we really don't want to break our knees. So we have a joint capsule that's strong and full of bursa. We have a joint capsule that's strong and full of fluid, full of tendons, and also fat to help create a barrier for trauma. So this is the anterior view of the right knee. So we're looking at the right knee in front with the retinaculum and ligaments. So that's what we're looking at right here. So this would be the tibial tuberosity. So this is the tibia, vastus lateralis. So the femur will come down here, and this is the tibia. So the condyles of the femur would be in there. The patella is underneath of this quadriceps femoris tendon, and then you have the patellar ligament. So the patella fits right down, right in there. So this is a picture of the joint capsule. This is the anterior view of the knee with the retinaculum and ligaments. So we're still looking at the knee in front, and we have a good picture of the semitendinosus tendon, the posterior cruciate ligament, the medial meniscus, lateral meniscus, the popliteus tendon that's curving right around laterally, that's going to insert into the femur. Axial T1 with an MRI of the knee with the patellofemoral joint. So here we want to identify the patella as well as the patellar tendon. The articular cartilage of the patella is important. Vastus lateralis, the IT band, the biceps femoris. We talked about all of those, the gastrocnemius lateral head, the gastrocnemius medial head, popliteal vein, semimembranosus, and semitendinosus. The tendons, we have to understand what those tendons are because we do many MRIs for pulled hamstrings. We have the gracilis tendon and the sartorius muscle, very important muscle to know in the femur. So coronal T1 weighted MRI of the lower leg, the peroneus longus muscle, the gastrocnemius muscle, and the soleus muscle. These are the three muscle groups of the lower leg that are major, that you should be familiar with. The peroneus longus muscle, the gastrocnemius muscle, and the soleus muscle. Major muscle groups of the lower leg. Now we're looking at a sagittal image, tibia, fibula. This is the femur up there. And we can see the lateral head of the gastrocnemius muscle. That is superficial, and the soleus muscle, which is deep. Soleus muscle, gastrocnemius muscle. This is a picture of the fibula coming down there because the tibia is anterior. And look, the extensor hallucis longus muscle is up in here, and this acts on the toes, the phalanx, the digits of the feet. So here are the bones of the right foot, superior view. And here are the phalanges that stop right up in there. Then you have your metatarsals, and then you have your tarsal bones. And we have the calcaneus, the big heel, the talus, which articulates with the femur, the navicular, which articulates with the first, second, and third cuneiform bones, and lateral to that is the cuboid. So when you do your lateral, you actually can see this like little hook aspect of the cuboid. Many times you can have a fracture of the cuboid bone, where the muscle will pull the little tip of the cuboid bone right off. Here's a lateral view of the bones of the right foot, and you see the cuboid, and you have, I believe it's called a Jones fracture. Don't quote me. We can look it up. I'll look it up after this. But is the tendon that can pull this little piece of fracture off, and you have to be careful because in children, is an ossification site, so you can't. That's not a criterion in children. But after the bone is fully ossified, if you see the distal tip of the cuboid pulled off from a pulling of the tendon that attaches to the heel, the navicular and the cuneiform bones, and the navicular articulate with the cuneiforms and also articulates with the talus. The calcaneus articulates with the talus and articulates with the cuboids. You have what they call a Lisfranc fracture. It's becoming very common. That's a fracture right there. named after a surgeon that used to cut off the feet of soldiers in war at that point in time. And then they have a chopar also, which cuts off that part of the foot. T1 with an MRI scan of the calcaneus. Calcaneus. Good picture of the talocrural joint, the ankle mortis, tibia, extensor hallucis longus tendon coming down right there. Good picture of the navicular bone right there. Again, a good picture of the cuboid bone. And here's an illustration of the coronal view of the subtalar joint. So this we looking at the subtalar joint in face. So you have the lateral malleolus, you have your medial malleolus, and this is the ankle mortis. Ankle mortis. You can have a fracture with internal rotation of the ankle, a distracted fracture, a avulsion fracture, and you can see the tip of that ankle bone come off. Talus, calcaneus, and this is important to identify also. This interosseous talocalcaneal ligament. So in a coronal view, you want to get a good picture of this. You want to see the ankle mortis. You want to get a very good picture of the interosseous talocalcaneal ligament. So here we have the ankle mortis, clearly identified. You have the tibia, you have the talus, and you have the calcaneus. The quadratus plantae muscle, flexor digitorum brevis muscle, how you curl your toes, abductor digiti minimi muscle, so these muscles flare out the toes. This is the sustenaculum tali. Right there, portion of the calcaneus bone. Bone. So now we have an axial T1 with an MRI of the left ankle. So this is the lateral malleolus. So this is the fibula. Okay, it's the talus. It's not the tibia, tibiotalar ligament. Tibiotalar ligament. So this ligament attaches to the talus. It also attaches to the tibia. The flexor hallucis longus muscle and tendon traverses posterior to the talus bone. So the flexor, and of course these flexor hallucis longus muscles is going to flex the toes. So of course it's going to wrap behind the talus and underneath the sole of the feet. So it can act on the plantar section of the feet, so it can flex the toes. Illustration of the feet. You have the fibula, tibia. We understand that, the anterior talofibular ligament. So what it's going to do is it's going to connect the tibia to the fibula. Then you have a ligament that attaches the fibula down to the talus of the foot. Metatarsals, phalanges, the tarsal bones. Remember, the navicular bone is going to be medial, that articulates with the three cuneiform bones, and lateral navicular, and lateral to the cuneiforms is going to be the cuboid. So the navicular bone is going to be posterior to the cuneiforms. The cuboid is going to be lateral to the cuneiform. Axial T1 weighted MRI of right ankle, and orient yourself with this picture. So this is anterior. Okay, so this is anterior. So here we have the talus. And we have a little snippet of fibula coming up there. The tibialis anterior tendon, we know that that's dark, so that dark spot anterior to the talus is that tibialis anterior. And just lateral to the talus is the extensor digitorum longus tendon, extensor. So you extending. Remember the flexor. The flexor tendon is going to come across the bottom and act on the toes to pull the toes down. The extensor tendons are going to come across the top and act on the toes to pull the toes up. Okay? That's the pathway of the extensors and the flexors. So when you see flexor digitorum longus tendon, you pretty much know the pathway of this flexor digitorum longus tendon. And we have the Achilles tendon right there. Flexor hallucis longus tendon. When you hear hallucis longus, that is the great toe. So axial T1 weighted MRI of the right ankle. Again, orient yourself to what you're looking at here. So you're going to be in bone at a point, then you're going to be in soft tissue, and then back in bone. So you're going to be in bone at a point, going through soft tissue, and then back in bone. Good picture of the cuboid there. And remember that avulsion fracture. The cuboid can is a quite common avulsion fracture. See it on your fat saturation or suppression images. Extra fluid in the region of the cuboid. The flexor hallucis longus tendon. The extensor digitorum brevis muscle, the cuboid. The peroneus longus tendon. We talked about that, the peroneus longus muscle in the leg, along with the soleus and the gastrocnemius muscle, and the calcaneus, the heel. Very familiar with that. Now we have a sagittal T1 weighted MRI of the ankle and ligaments and tendons. So here you have the flexor hallucis longus muscle, right? So that muscle is going to come down and go through there, the flex, the hallucis longus. You have the extensor hallucis longus tendon. Remember, cuts across like that. The medial cuneiform, so we have the cuneiform, posterior to that is going to be a navicular bone, okay? The cuboid bone is going to be lateral. So lateral cuneiform, cuboid bone, posterior to the cuneiform, it's a navicular bone. So coronal T1 weighted MRI of the left ankle again. Get yourself familiar with the orientation. We're going straight down the leg here, so we have a good shot of the tibia, fibula, talus, calcaneus. Boom, we have that. We understand that. Abductor digiti minimi muscle, plantar fascia. This is what the heel spur is when it calcifies. Okay, abductor hallucis muscle, abductor. So it's going to pull it away from the body, abducted. And another coronal T1 weighted MRI of the left ankle. This one is pretty busy. We're going to have a lot of anatomy on this page. The tibia, fibula, talus, calcaneus. We're familiar. with that. Flexor digitorum brevis muscle, we discussed that on the previous slide. Plantar fascia, we discussed that on the previous slide. Abductor hallucis muscle, we can follow that down. Cystinaculum tali, we talked about that on the previous slide, part of the calcaneus bone. Okay, coronal T1 weighted MRI of the left ankle. Again, fibula, talus, calcaneus, the quadratus plantae muscle, but we talked about the flexor digitorum brevis muscle and the plantar fascia, abductor digiti minimi muscle, the sinus tarsi. Sinus tarsi is in between the talus and the calcaneus. That's where the ligament resides, the cervical ligament. But it's important to get a clear picture of that. And now we're looking at the digits of the feet. So you know the extensor group is going to come there. The flexor group is going to come down there. See, flexor hallucis brevis muscle, flexor hallucis longus tendon. The flexor hallucis longus tendon acts on here, pulls this down. You have the extensor hallucis longus tendon, acts on there to pull it up. First distal phalanx right there, first proximal phalanx. We have an axial T1 weighted MRI of the foot, and as you can see from the image, we're going to get a picture of the flexor group and a picture of the extensor group. So here's the flexor hallucis brevis muscle, and you can follow it down. Remember, we said the flexor hallucis, and when we see hallucis, we know that it's going to act on the great toe. We know we remember the interosseous muscles from the carpal, metacarpal. So the interosseous muscles is just a short way of saying muscles in between the bones. Yeah, the fourth metatarsal, the base of the fourth metatarsal, and the cuboid. It's a tarsal metatarsal joint, or the cuboid metatarsal joint. So you name the joint from proximal to distal. And the illustration of the extensor tendons of the lower leg. So we can see that the extensor tendons actually begin way up, way up, way up in the leg, and you can follow it down, go right underneath the superior and inferior extensor retinacula, and act to extend the toes, pull them up. Okay, now you have the flexor hallucis longus coming right through here, right underneath the fibular retinaculum. This is a retinaculum right there. This is what you would call like a retinaculum. The whole thing's in place, and you can see it lined right up underneath of there. And what it's going to do is going to act on the toes to pull them down. So it's not this band that's pulling into this pinky toe here. The flexor hallucis longus is actually going to wrap underneath of the toes to pull on the hallucis, or the big toe, great toe. Interosseous muscles, of course we know them. They lay adjacent to the metatarsal bones. Fibularis longus tendon. This is a dorsal view of of the muscles of the right foot. But here we go. Adductor hallucis, transverse head of the adductor hallucis. So you have, sorry about that. This is the adductor hallucis muscle. And you see what it does. It acts on the inside of the toe. So if your toe was out, it would bring it back in. That's why it's called the adductor. And you got the adductor hallucis, the oblique heads of the adductor hallucis. It's pulling right on this great toe. The flexor hallucis brevis, the flexor hallucis. So this is a dorsal view. So this is like if someone was step, you're looking from underneath of the foot. Okay, so you see this muscle inserting right here. It's going to pull the toe down. And then you have your flexor digiti minimi brevis groups. So you have the flexor digiti minimi, and it's going to flex. So it's going to pull them down. It's going to pull them back down, like if you was to try to grip something with your toes. And here we have a coronal view of the muscles of the foot of the metatarsal. So if you was to chop it down, this is a good view to see where the flexor and extensor groups will be. So this is the metatarsals right there, and these are the interosseous muscles. We learned about them. Before. And here we have the adductor hallucis, oblique head, flexor hallucis, and the abductor hallucis. So the abductor is going to pull it away from the body. So it's going to pull this toe out. Flexor is going to pull the toe down. And here we go with the tendons of the extensor hallucis brevis, which is going to act on the superior side of the foot to pull the toe back up. And here's the anterior view of the veins of the lower leg. So here we have the inferior vena cava, and this is just something that you're going to have to remember. You have the common iliac, which turns into the internal and external iliac, turns into the femoral vein. Now the great saphenous vein lays deep or medial to the femoral vein. The profunda femoris vein is important to understand, because after the profunda femoris vein you get this inferior epigastric, recurrent epigastric that runs back up into the rectus abdominis. But here you have the femoral vein and the great saphenous vein, and you can follow the femoral vein all the way up into the popliteal. The great saphenous vein is going to go all the way down. So you see how the great saphenous vein is going to be medial to that, and it travels all the way down. The femoral vein is going to turn into the popliteal vein, which is going to turn into, which is going to bifurcate into the fibular and the anterior tibial vein. Dorsalis pedis, and that's where we palpate. And the dorsal venous arch is the arch, this little recurrent loop of the venous system, and which supplies blood return from the metatarsals. So we flip the leg backwards. You have your great saphenous that travels all the way down uninterrupted. Don't turn into anything, and stays the great saphenous. But you have the popliteal that travels down the back of the leg there, and then after the popliteal, it bifurcates into the fibular and the anterior tibial. So the anterior tibial will traverse the fascia plane between the tibia and fibula to travel anterior to the tibia, and then it'll bifurcate, turn to the posterior tibial vein, and then you have the plantar veins, the plantar arch, and the digital veins. So anterior and posterior views of the right leg and foot with the nerves, and how the distribution of the nerves. So you have the sacral plexus. Yeah, the sacral plexus, and the pudendal nerve is a nerve that we actually if that runs adjacent to the ischium. Okay, so that's one of them pelvic nerves, but the sciatic nerve comes off the sacral plexus, and there's the sciatic arch. So that sciatic nerve travels down the back of the leg. And then you have the femoral nerve. But this is innervation of the lower extremity. So if someone has a nerve sensation down here, it could be a problem at the sacral plexus. It can also be a problem or impingement of the nerve at the lower back level. That has been sectional anatomy. It was a pleasure. See you in class.